This is Resilience Radio. We're talking about infectious disease and medicine. I'm Irvin Eisenberg, host for the show and owner of Resilience Occupational Therapy. As always, the opinions on this show do not necessarily reflect my personal opinions or the opinions of Resilience Occupational Therapy. I like to feature a variety of different perspectives. Everyone has different needs, and this is not meant to be medically diagnostic or prescriptive in any way. Today's guest is Dr. Jessie Leyse. She is a medical doctor with a specialty in infectious disease. She has been on several healthcare and public health-related international trips. Jessie is the only infectious disease physician at Central Vermont Medical Center. She sees patients in the hospital and the clinic. She treats a variety of infectious diseases. She's also the head of infection prevention at CVMC and does some work in epidemiology. It's really great to have you on today.
Thanks. It's great to be here.
Can you start us off with sort of your journey to become an infectious disease doctor?
Sure. It's sort of convoluted, as I'm sure most people's stories are. I grew up in Indiana on a farm, loved animals, had some horses when I was growing up. And so I wanted to be a veterinarian when I was younger. Pretty strongly. I was certain I was going to be a veterinarian. And then after my freshman year of high school, so I was 15 or so, there was a group going to Honduras to help build houses after, I think it was an earthquake. There were a bunch of mudslides, and so people were going to help build some houses. So I went there and built some houses with some friends and really enjoyed seeing different cultures and meeting different people and doing something useful. And so over the course of the next several years, I went to different places. I went to Mexico with my family, and we did some work at the landfill. So people work in the landfill and pick up things that they can sell. And oftentimes they get injured. And so there was also a doctor on that trip, and I just assisted with getting the medications out that she was giving to people. I went to the Philippines for 6 weeks during the summer, also during high school, and helped at a maternity clinic. So helped deliver babies I was basically just watching, but there were a bunch of midwives there, and we also toured or helped out at a home for malnourished children. And so over the course of all of those trips, I started thinking, I really enjoy being useful to people and helping people that maybe wouldn't get this care anywhere else. And so it felt odd to me to want to be a veterinarian and help animals when there were so many people that were in need of assistance. And so I sort of started shifting my goals to becoming a doctor. And then, lots of other trips trying to figure out what to specialize in over the course of college and med school. And I couldn't narrow it down. So I ended up doing a med peds residency, which is internal medicine and pediatrics combined. So each one separately is usually 3 years. When you do the combined, it's a 4-year residency, and then you can be boarded in both internal medicine and pediatrics. And it was just a way to not have to make a decision right away and not have to narrow down my path. And so I did med peds, and then at the end of that, I was trying to figure out, all right, how am I going to use this how I want to? How can I specialize to do what I want to do? Which basically was global health was the big thing that I wanted to be a part of. And the two main paths were either infectious disease or a global health fellowship, one of those two fellowships. And so I decided that I was probably going to be working mostly in the US and then doing some international travel. So the infectious disease fellowship made more sense to me to specialize in, because I would be spending the majority of my time in the US rather than a global health fellowship. So that's how I ended up doing infectious disease.
Could you speak a little bit to what infectious disease medicine is and and how that relates to sort of the global aspect.
Yeah. Infectious disease is basically anything that can be transmitted to humans. Infections between people, influenza and colds and hepatitis and those sorts of things that can be transmitted between people, but also diseases that can be transmitted from animals to humans. So you think about tick-borne diseases, or there's parasites that we can get from different animals. So anything that is, I guess, not necessarily supposed to be in your body or not part of your body, but is causing a problem that we need to get rid of or address. So I deal with a variety of things. So it's skin infections and viruses, fungi, bacteria. There's a lot of different infections that people get that I can help with. And the reason that deals with global health is because a lot of issues in global health are related to infectious diseases. So you think about malaria, is a really big one, the HIV pandemic. A lot of the big illnesses, not big illnesses, but major illnesses that affect lots of people tend to be infectious. And the thing I enjoy about it is that most of the time there's an answer. There's something I can do to help fix the problem. And a lot of times it's a fairly simple thing. It's a medication or something that resolves the infection. Whereas a lot of the other parts of medicine require a lot more structure to help alleviate the problem. So if you think about diabetes, for example, there's a whole infrastructure that's required to treat someone with diabetes. You have to have the ability to diagnose it. You have to have the access to medications. You have to have nutritional information. You have to have the resources to get all that stuff to the patient. So transportation and the diabetes supplies, all of that is infrastructure, and that can be a much bigger issue and much more difficult to address. And so I guess I sort of took the easy way out, and so I didn't have to address those infrastructure issues as much with the chronic diseases like heart disease and diabetes and high blood pressure, that sort of thing. Those are certainly big issues internationally all over the world, but they're a little bit more difficult to address than a simple infection is.
So as far as like a simple infection, it seems like it had such a broad scope of things that are infectious. Sort of two things that came to mind. One is, why aren't there more infectious disease doctors if you're the only one at Central Vermont Medical?
Yeah, it's a really fun and broad specialty. We see a ton of different stuff, but as far as I guess the other two things that you think about, or that people in medicine think about, are time. So how much call you have, how frequently you're on call, whether you have to go into the hospital when you're on call, and then also the reimbursement. So not just pay scale, but how well insurance reimburses a specialty. And in general, higher reimbursements go to procedural specialties like orthopedics, dermatology, those specialties that they can physically do something to the patient, do a procedure, whereas the primary care specialties like pediatrics, internal medicine, infectious disease often gets lumped into sort of a primary care lump, I guess. they tend to have lower reimbursement a lot of times because patients don't have insurance, or they don't have great insurance, or they're on Medicaid or Medicare, who tend to be lower at reimbursing than some of the private insurance companies. So that's part of it as well.
Okay, so it seems like it's one of those specialties that requires special training, but the medical payment structure doesn't actually treat it as that, having much more than the general practitioner.
Yeah, that's a good way to think about it.
Yeah, so the hospitals are not incentivized to really have many of you.
Right. Yeah, and UVM has a lot of them, and CVMC is part of the UVM Health Network, and so if I wasn't at CVMC, the ID docs up at UVM would cover that, but it wouldn't be someone in-house. So patients would have to travel up to UVM to see one of their docs in clinic, or it would be a phone call between the infectious disease doctor and the hospital attending, seeing the patient in the hospital. Whereas since I'm there on site, I can go over and see the patient in the hospital physically, and it helps with people who have transportation issues that can't get all the way up to UVM.
The infectious disease work, in some ways, I think you're not having to change the entire infrastructure. There usually is an answer, but I imagine it's not always easy to find that answer. I think you've talked about enjoying the puzzle of the work.
Yeah, it's often, I feel like, a detective. And I sort of lump infectious disease in with rheumatology in this way, that a lot of times we get referrals because people have gone through loads of testing and they just can't find a reason for their symptoms. And so it sort of ends up falling to either infectious disease to try to figure out, is this some sort of infection that we haven't figured out yet, or rheumatology, who deal with autoimmune diseases, to figure out if that's the cause of the symptoms. So a lot of times patients that I see in clinic have seen numerous other specialists and have had a battery of tests and scans, and nothing has come up to say, yes, this is your diagnosis. This is the reason for your symptoms. And so I'm tasked with trying to go through all of the history since they started having symptoms and all the workup that's been done to try to figure out what the actual cause of symptoms is. And that is very time consuming usually. And a lot of times the patients are pretty frustrated by the time they see me because they've seen so many specialists already and haven't gotten an answer. But it makes it certainly more interesting to try to dig through the puzzle and ask all the questions about where they've traveled to and what sort of animals they've been in contact with and what they've eaten in the last 2 years that could have caused an infection that is causing their current symptoms. So it's often a lot of discussion about risks and what they've been exposed to try to figure out if there's some hidden infection that nobody has found yet.
Do you have any sort of examples of a source of infection that you were that was sort of obscure, or that you were proud of yourself for having figured out?
There's been a few that have been interesting. So Legionnaire's disease, I don't know if you've heard of that. You heard of Legionnaire's?
I don't know much about, but
it's a respiratory illness that usually comes from standing water or sources of water. So the classic story about how it was discovered was this large convention that the heating and air conditioning ducts were contaminated. And so everybody at this conference got Legionnaire's disease, which is a respiratory illness. And so we had a patient who came in with a really severe pneumonia, who was otherwise a very healthy person. And going through the history and trying to figure out what the risk factors were, we discovered Legionnaire's disease probably from the air conditioning in his truck. Like, he was a long distance truck driver, and most likely the air conditioning unit in his truck caused his Legionnaire's disease. So there's testing to get at that specific diagnosis, but then trying to ask the questions about where they've been and what they've been in contact with, and going backward to try to figure out where that exposure was, also plays into public health a lot, which is really interesting because you want to make sure that there's not something he was exposed to that other people could potentially be exposed to and also get sick. So, you want to make sure that it's not an air conditioning unit at a motel or something that a bunch of other people are also going to stay there and end up getting sick. So the epidemiology and the tracing back to try to figure out a source to make sure that no one else comes into contact with that source is also a really interesting part of the job. And a lot of times that goes along with the public health departments and,
So are you ever put in the position where you're having to call up the motel and be like, so we think your there's a problem with your air conditioner that's going to make people sick? Or where's the the reaching outside of the patient that you're working with, that responsibility, or what you've had to do with that?
So I would usually ask the questions to figure out where the potential source was, and then call the Vermont Department of Health and say, I have this patient with X, Y, and Z. Here are the potential sources that I identified in an interview. And then they would go through all of that and decide if they needed to contact the hotel or, the trucking company or whoever they feel like they needed to contact. So usually that doesn't fall on my shoulders, which is great because it's a lot of work. They have whole departments dedicated to that sort of work. But I get the fun part of asking the weird questions that people often look at me like, why are you asking me about my dog when I was 7 years old?
It seems reminiscent of sort of the House episodes of the medical detective.
Yeah, that's sort of what it feels like sometimes when I'm asking all these really obscure questions that people just give me a sideways glance. It's sort of fun.
So what are the biggest infectious challenges in Central Vermont?
Honestly, I think the infections related to IV drug use are probably the biggest challenge and what I deal with mostly on a daily basis. We certainly have other things like tick-borne diseases that are really common, but there's, in the last several years, and especially with COVID, I think it's gotten worse. There are diseases that are transmitted between people when they share needles or, bloodborne diseases, and not having clean skin that they're injecting through can introduce bacteria into the blood. And so some of the things to think about that I help treat are hepatitis C infections. We have a really high rate of hepatitis C, and that's mostly related to IV drug use. And then the issues related to injecting through skin where you have bacteria. So abscesses that have to be opened up and drained, infected joints, heart valve infections or endocarditis is another big one that, the needle goes through the skin into the blood, and it also can carry some of the bacteria that's on the skin into the bloodstream. And then as that circulates around and goes through your heart, some of those little bacteria can sit down on the heart valve and cause what's called a vegetation. And that just leads to this constant bacteria flow into your blood, and it can cause abscesses in your lungs, in your brain, in your joints. People can become very, very sick with that. It can cause damage to the heart valve itself. And so people sometimes have to have their heart valve replaced and have to have surgery to put in a new valve. And then they're at higher risk of infection of that prosthetic valve. So I think treating substance use disorders is a major concern. And that doesn't just involve infectious disease. That involves a lot of different, primary care access and access to Suboxone and methadone and psychiatric facilities and rehab facilities. All of that goes together to help reduce the risk of relapsing or the risk of continued IV drug use. But I know especially in Vermont and most of the country, I guess, we have a really dire need for psychiatrists and psychiatric care, that it's just a huge open void that we need more providers to be able to provide that. And because we don't have that, I think there's a lot of relapse and a lot of infections that happen related to substance use.
So you're saying that a lot of mental health related challenges leading to continued substance abuse, and then you're dealing with the infections sort of downstream of all of that.
Yeah, I'm sort of dealing with the physical consequences of that mental health crisis.
And it's interesting when people think of mental health and drug addiction, they don't jump to infection as the end problem from all of that. Immediately, we tend to think in terms of other overdoses and some of the things that we're more likely to see on TV, I suppose.
Yeah, it's and those definitely happen. It's just that some of these consequences, the infectious consequences, take weeks and weeks to treat, and people end up being in the hospital for months at a time. So it's a big issue for the medical system as well as for the patients that have to deal with it.
So we've not really talked about COVID much at all, and I'm sure many people are tired of hearing about COVID. But I feel like that COVID is an infectious disease event that is definitely affected everyone, and both globally and locally. Do you feel like there are any particular lessons that we should be taking from this experience?
Early on in 2020, I started keeping a list on my phone of ways that we could improve for the next pandemic. And I felt like I was adding to it every day. The lessons that we've learned and things that we stumbled over and maybe could have done more smoothly, or I think a big theme that kept coming up was better communication. And so better communication with the public about what's happening, what the recommendations are, what the science is behind some of this stuff, as well as communication between groups and not duplicating the work, and being as efficient as possible when there's so much happening. And I think communication is key for most things in life, including pandemic response. So, it's tough when there's not a ton of time to have discussions. So I feel like a lot of times we just don't have the time to spend to go through and talk through the science behind the vaccines, or the transmission, or why masks work, because there's so much other logistic stuff to do that it's hard to make time for that. But in all honesty, that's probably the most important thing that we can do, is take the time to explain in as many different ways as possible how this works, how the science works, why we're doing what we're doing. Because if people understand it, I have found they're much more likely to do what you're asking them to do, because they understand the why behind it. Rather than me just saying, you need to take this antibiotic because X, Y, and Z. If I explain the illness and explain what the antibiotic does and why it's important to take it to the end, people are much more likely to follow instructions. So that's a big one, the communication. And I think coming back to trusting science, trusting the scientific method and that process. I know a lot of mistrust has come out, and especially during the COVID pandemic, and it's been really politicized. And ideally, science wouldn't be politicized. It's not part of one particular party or another. It is what it is. You know, it's trying to come to the logical conclusion of the facts, not being bent by ideology. Ideally, you know, we don't. So it's not perfect, but I think in medicine, it's the best that we have to try to discover the truth and make the best decisions that we can based on the facts that we have at the time. So trying to reinstill the trust in science and medicine is important over the next several years and decades. I think a lot has been broken down in the last couple of years with COVID. There's just a lot of mistrust of the medical community, and you know, some of it's justified based on history, some of it's not justified. So we have a lot to do in medicine to try to regain people's trust and explain what we're doing and why we're doing it in an open manner.
Well, I think that's a good note to go out on. Thank you so much for coming on today. It's been a pleasure talking with you.
Thanks for having me.
Thank you to Aaron Marcus for providing us with the music for this show from their tune Some Biological Process. For full credits on that track, check the show notes. I hope you enjoyed this episode. If so, you can review it on the podcast hosting website of your choice. And you can also subscribe and get more interviews with different healthcare practitioners.